Hello and welcome everyone. Thank you so much for joining us tonight for a panel discussion about the impacts and observations from COVID-19. I'm Christine Clark, Director of the Master of Science and Threat Response Management Program at the University of Chicago. We are co-sponsoring this event along with our Master of Science and Biomedical Informatics program. We're joined tonight by a panel of experts from the teaching and alumni community of both programs. They will be sharing their observations of what has transpired, the cascading effects, and how organizations have adapted since the World Health Organization declared COVID-19 a pandemic over 2 months ago. I'd now like to provide a brief introduction of each panelist. Dr. Rebecca Wirtz is our moderator for the discussion. She is an infectious disease specialist who has worked as the Deputy Medical Director of the Illinois Department of Public Health, has held the Chief Medical Officer role for a variety of organizations, and has directed Master of Public Health programs previously at Northwestern University and currently at the University of Minnesota. Dr. Wirtz currently lectures in our Threat and Response Management program. Dr. Sam Boltenbaum led the development of our Master of Science and Biomedical Informatics program and continues to serve as faculty director. He's Associate Professor of Pediatrics, Associate Chief Research Informatics Officer, and is currently Dean of Master's Education within the Biological Sciences Division at the University of Chicago. Dr. Katherine Foster is a longtime practitioner of public relations and communication studies. She managed media relations at Argonne National Laboratory for 16 years and currently lectures for the Threat and Response Management program. Dr. Kiljun Kim is a senior policy analyst at Chapin Hall at the University of Chicago. He provides support for government agencies across the country in child welfare and education around the issues of implementation science, data-driven practices, and continuous improvement. His research includes ecological approach in public health, and he currently lectures for the Biomedical Informatics program. Dr. Stephen Wine is Professor of Psychiatry at the UIC College of Medicine, where he is also Director of Global Medicine and Director of the Center for Global Health. Dr. Wine currently lectures for the Threat Response Management program. David Bunke is Manager of Emergency Preparedness, responsible for developing, implementing, and maintaining a successful emergency response program at the ComEd Electrical Utility. He is a graduate of the Threat Response Management program. Tom Russell currently serves as Gallagher's Global Director, where he is a Senior Resilience Leader. Tom oversees the company's global crisis management, business continuity, safety and security, and operational risk organization. Tom is also a graduate of the Threat Response Management program. I'll now turn it over to Caroline Roth, who is the Program Manager for the Threat Response Management program. She'll review the agenda and format of tonight's discussion.
Caroline, you're on mute.
Thank you very much. Can you hear me now?
Yes.
Okay, thank you. The format is we will have 5 discussion topics and plenty of time for a Q&A near the end of the event. So please submit your questions in the chat box and we will ask the panelists a few questions at the very end. Zoom etiquette, please remain muted and keep your video off. And like I said, just put the questions in the chat box and we will save them all for the very end. So now I'll toss it over to Rebecca.
Thanks, Caroline, and welcome this evening, this afternoon, depending on where you're tuning in from. We've got a very interesting panel of experts who have chosen several topics that they thought would be of particular interest to the audience in understanding and responding to the current pandemic. As Caroline mentioned, we'll work our way through the 5 different topics. Each expert has chosen to focus on one. There will be some dialogue among the experts at the end of each topic, and then at the end of the hour-long sharing from the experts will be open to questions. So I'm going to turn the first discussion over to Dr. Katherine Foster, who's going to emphasize the importance of clear and unambiguous communication in responding to emergencies.
Thank you, Dr. Wirtz. I'm always a little scared when people think of me as an expert because I do not pretend to be, and I do not play one on television. But what I am is a person who has studied communication in a variety of situations and lived a long time and seen a lot of it. And it seems to me that crises that are managed well are ones that are communicated clearly to affected stakeholders with action messages. And by using that term, I'm talking about telling people things that they can do or things that they need to know how to do if particular situations arise, so that they feel more in control of the situation than they would otherwise. So that sort of leads me to the idea of who can deliver those messages well, and how can those messages be developed. And so if we look at the research, back in the late 50s and early 60s, a communications researcher named Kelman developed a model of source characteristics. That's the terminology that he used. And he determined by studying a lot of different communication settings and looking at how messages were delivered through various spokespeople, that people responded to spokespeople who had credibility. Now that sounds pretty simple and straightforward, but where does credibility come from? And a big part of that, Kelman learned, is that if a source is perceived as having knowledge and also being willing and able to give an objective opinion about that knowledge, then they're perceived as having credibility. The second characteristic is attractiveness. And fortunately for most of us, that does not mean you have to be pretty to be believed. But if a source connects with members of an audience in such a way that the audience identifies themselves in some way with the messenger, or wants to be more like the messenger, then that person's message is more likely to be believed and acted on. Kelman's third characteristic was source power, which we probably won't talk a lot about tonight, but I mention it just to be complete. Source power is present when the source of the message has the ability to reward or punish people in the audience. If influence comes through forced compliance, for example, if the recipient is looking to be rewarded or to avoid punishment, then the communicator is said to have some form of power. But it's primarily source credibility and source attractiveness that I want to talk about tonight, and I want to talk about it in the context of research that has been done over the years, begun by Cassiopo and Petty, who developed what they called an elaboration likelihood model of persuasion. And the idea of that is that we are more likely to be persuaded, or at least to listen, if we're interested, if we care, if we see that some issue has importance, relevance, circumstance for us, then we want to know more about it. And so we're not just passively waiting for somebody to tell us, we are actively seeking information. So people on that end of the spectrum want details. And Cassiopo and Petty used the term central route. This is the route that communicators would use to provide information, to provide detail, to provide background. The other end of the spectrum is a little less interested, maybe a lot less interested, maybe even hostile. And the folks on this end of the spectrum need to be persuaded in a different way. They need to be persuaded through what they call the less direct approach. And in using that approach, we want to use slogans. We want to use memorable messages. We want to use some level of drama or shock to get people's attention, to make them more aware of an issue. And I talk about these things to sort of lead us to talking about the three most prominent healthcare experts that we've been listening to over the past months, because I think they neatly put themselves on that continuum, and that they each carry some level of credibility and attractiveness that causes us to listen to them. And the first one is the most obvious one, Dr. Anthony Fauci, who is director of the Infectious Diseases Institute for the National Institutes of Health, and who is a member of the coronavirus task force, and who we see on our televisions on an almost daily basis. Dr. Fauci seems to be a very credible source. He seems to be a very, because he's able to talk to people in language that they understand. He's able to say that masks are important, for example, and why that is the case. So he's delivering messages kind of on both ends of the spectrum a little bit. So he is sort of more in the middle. I think I would put Dr. Burks, who is the chair of the task force, and who we also see on an almost daily basis, and many of us have come to admire her scarves. She's really giving us a lot of intense detail. Her responses to questions, her presentations at press conferences are usually very heavily full of data. So the people who are interested in following this direct route to information find her appealing, because she's giving them the kinds of information that they're looking for. And the third person that I would talk about tonight is Dr. Adams. Dr. Jerome Adams is the Surgeon General. He is not an infectious diseases expert. He's an anesthesiologist. So he's not pretending to have expertise in this particular field, and yet he is, as he reminds us almost every time he's interviewed, America's doctor. And he speaks very well and clearly about the need to wear masks, the need to wash your hands, the need to socially distance. And he uses a lot of slogans when he speaks. I have heard him say on at least 6 different occasions that his job is to take care of the people who take care of the people. In other words, we're doing a lot of what we're doing not only to protect ourselves, but to protect the healthcare professionals who would have to deal with us if we became sick. And so he's trying to appeal to sense of community. He's trying to bring up some level almost of patriotism in trying to deliver his messages. And his messages are almost always clear and resonate with some sort of slogan type quality. And so they fit very strongly on the peripheral end of the spectrum. He's talking primarily to people who are less interested in the detail and maybe are feeling mildly inconvenienced or greatly inconvenienced by what's being asked of us in this pandemic. And they just need some reassurance that the sacrifice is worth it. And I think Dr. Adams speaks to that on a fairly regular basis. So from that perspective, I think the three healthcare professionals have their messages in order and are delivering them to key segments of the audience and doing it fairly well.
Thank you, Dr. Foster. Those are three national and high-level speakers. Dr. Volchenboom is a doctor in Chicago, deeply embedded at the University of Chicago. What can you tell us about sort of people on the ground, people trying to convey reassuring or at least accurate messaging to people in the city of Chicago?
Yeah, thank you. I mean, it's been a really interesting and wild ride watching this unfold over the past few months. And I've continually impressed with how University of Chicago at least has managed their response. It started in late February, early March, where we started to get very well organized top-down communication from the hospital's leaders. They had set up a hospital incident command system that was very strong in their communications, and every day we would get an email that would tell us how many patients were in the hospital, how many patients were being tested, even how many ventilators we had left in stock. I mean, it was amazing to watch this happen every day. And then that trickled down to the other leaders. So we got information not only from the dean, but we got it from our section chiefs, our department chairs. And it really gave you a strong sense that there were people in charge that knew what was going on, that knew what they were doing. And if you expand out from there, I think all of you saw Emily Landon give her press reports on TV, standing in front of J.B. Pritzker, and she conveys a sense of we're in control. We know what's going on, and when she tells you you need to wear a mask or you need to stay home, she does it with a sense of gravitas. And just as Katherine said in her remarks, she has the cachet, she has the experience, she has the power and the ability to convey those things. So I'm really impressed with how well this was done, both hyper locally at the UChicago level and locally around Chicago. And then one more thing, I think we all were very appreciative of the response of our mayor, and I think she's done a tremendous job in seeming very strong and powerful and in charge. And you never had to doubt that she was reading the science and that she was taking information in and that she's using data to make her decisions. So I'm very proud of Chicago and how we responded, and I hope to see that continue.
Wonderful, thank you. I think we've all learned lots of lessons about communication and how much leadership depends on quality communication. And I expect there'll be 100 years of study of this outbreak and what worked and what failed with regard to communication, and as well as many other things. I think we've all been amazed at the tidal wave of information, the tidal wave of data, of scientific publications, peer-reviewed and not peer-reviewed. And Dr. Kim was going to speak a little bit to the issues around managing data when we're uncertain of the quality of the data. There's less time and less attention given to its review. Dr. Kim, would you speak a little bit to that topic? What it's like to manage this tidal wave of data and information?
Sure, it's a bit of an extension of that conversation about communication, right? So the way I thought about this was sort of touching upon this issue of communication at the different phases of data analytics. So if you think about how much information we're getting on a daily basis, that would mean that there are people that are providing, in other words, they're producers of data. But by the time that information is consumed, there's a bit of an issue with communication, because what we have is very often snapshots or a sort of at best, a condensed version of information. And that's what we're getting on a daily basis through media. And sometimes it carries a danger, because when information gets chopped off, I think the important nuance gets lost, and when it compounds, and nowadays where information gets updated on daily, if not hourly basis, I think it carries a hidden danger. And a great example, I think, is the CDC report about COVID-19. Right now, the message that a lot of media is putting out is that there's increase in testing and then decrease in death rate. CDC makes it very clear on their website that part of that can change very rapidly when there's an update on reviewing of death certificate. In other words, a spike in death rate can appear later upon review of death rate, which is not reflection of reality so much as it's about making sure that there's a quality data that's provided to the public. Now, if you see those information change later without knowing that it's a logistical challenge of reviewing the death certificate, you're gonna simply see that as a spike in death rate. I think those kind of a detail that is really important when you're conveying a message can easily get lost. So I think that's sort of early phase of the communication and data link that's important. But the encouraging part about the analytics is the fact that there's more what I would call interdisciplinary considerations. So as statistics evolved into and fit into a lot of disciplines, we kind of settled into sort of go-to methods by different disciplines. Public health has its own, economics has its own, political science has its own. So there, across many disciplines, what it means to do data analysis has become very different. But now that we're facing this very different challenge, there's a lot of borrowing of concepts, and there's a lot of application of concepts that haven't been tried in one discipline that's being borrowed from another. I, for one, is doing exactly that in my work in child welfare. And the concern right now is there's a dramatic decrease in hotline calls and investigation for children that are potentially being abused and neglected because they're not in school and the mandated reporters are not present to observe those children. So the anxiety amongst child welfare agency right now is what would happen in the fall when the schools come back, when things, quote unquote, get back to normal. Would there be a spike? Would there be sort of backlog of investigations? So there's a great deal of anxiety. And to anticipate that, I'm doing predictive analytics, borrowing concepts from economics when it comes to latent demand, and I'm doing time series to anticipate reports, those kinds of things that really is outside the box in terms of analytical tools in child welfare. We are definitely considering that. Same thing with in education space where there's a whole lot of concerns about learning loss that's happening right now due to this changing in format in mid-year, compounded by summer learning loss. So there, those kinds of things can be also disaggregated through more sophisticated analytics. I think those are the things that really haven't been considered by different disciplines, and it's really good to see these different types of considerations. I think the one that I like the most is how prevalent spatial analysis is. I think a lot of people are looking at maps, thinking about the concept of, whether knowingly or not, thinking about things like looking at hotspots, and the importance of geography, I think, has been elevated through this experience. And I think that's a really important point. I never thought that I would teach my 5-year-old son maps through this crisis, but that's something I'm doing with my son every morning. And the fact that we can actually look at variations of infections through maps, I think is really educational for all of us. And the third part that I kind of wanted to touch upon is this battle that goes on between scientific findings and misinformation. And, we can certainly talk about a lot of misinformation that's generated in the public space, but that also goes on in specific areas as well. In fact, I was just reading the paper this testing company put out about how damaging this learning loss is during COVID period. If you read that paper very carefully, it was incredibly self-serving. It wasn't terribly well done. The bottom line of that paper was that because there's so much loss and it's so devastating, that testing becomes even more important. Come and use our assessment. I think the fact that these messaging is couched and framed as a legitimate research is very dangerous, because now we're battling this scientific findings that are sort of framed as marketing tool, and when the information is conveyed that way, I think it even heightens the anxiety. I think it makes the decisions very murky. I think those are the things that really is dangerous when the general public, or even in certain professions, where that line between solid analytics and those that are poorly done but packaged nicely, when that line is murky, it is very dangerous. And that's why in my intro to analytics class, one of the things that we talk about is that the producers of analytics, like ourselves, really need to be the biggest skeptics of the analytics, so that we can be the ones that are most critical in the process of disseminating information.
Very interesting, Dr. Kim, and it sounds like you're doing a fantastic job of homeschooling when you're teaching your son social demography on the fly. He'll come out of this a GIS guy for sure. So I've heard the metaphor that we're bolting the wings on the plane as we're taking off without enough parachutes, without enough PPE to go around for everyone on the plane. And I think that the way that data is accruing is part of that acceleration as we take off, trying to understand which parts of the data we can believe and understand. I know clinicians have been learning this disease on the fly, and I was going to turn again to Dr. Volgenboom just to talk for a second about what it's like to be a clinician in the setting of learning at the bedside about patients about this disease.
It's been a really wild ride. So I'm a pediatric oncologist, so I'm a cancer doctor, and I was actually on hospital service during one of the first big weeks that this hit. It was in March. And we basically had things changing hour to hour in our approach to taking care of patients. It was, we would get emails about what we should be wearing, how many people could be seeing the patient every day. We were doing rounds on iPads, and parents were talking to us virtually. It was just incredible. I've never seen anything like it, how fast the landscape changed and how quickly we had to take in new information. Fortunately, of course, as people know, kids have done very well, and we fortunately, even our kids with cancer have done quite well. In fact, we're seeing actually a decrease in admissions to the hospital because kids are not going out of the house. And so normally we would have kids come in with and get fevers, and they'd have to come into the hospital, and kids are staying home now. So it's going to be really interesting as the restrictions are lifted to see what happens to the kids coming in the hospital. We had a lot of communication with our adult colleagues, because we were watching very closely the census on the adult side, and we were at the ready actually about having to take adult patients into Comer Children's Hospital, and there was a whole plan in place to bring in non-COVID patients from the hospital to Comer. Unfortunately, it never got that far, but we were ready to start taking care of adult patients. I mean, it was really day to day, hour to hour, and again, as we said before, having strong communication from the top down, where we knew somebody was in charge, we knew that somebody had our backs, was really important. And in the end, I think that made a huge difference to us to know that the decisions were being made with as much data as possible.
I'm thrilled to hear you say in the end. I didn't know we were there yet, but it's good to hear.
Yeah, I mean, I think we were waiting for this big spike, and I think everyone in Illinois and Chicago has done a great job, and we certainly are still seeing a ton of cases, and we know that it's going to be a long time before this is over. But at least that major spike where people were really scared about running out of materials and running out of ventilators, it doesn't look like that's going to happen right now. So we're all relieved about that.
That adrenaline charged first few weeks has passed, yeah, better than anything I think any of us could have hoped. So Dr. Kim referred to things like domestic violence and children falling behind because they're not in school. And I think turning to the third topic, this has been receiving some attention that in any trying or tumultuous or chaotic times, the same people suffer as who suffer at baseline. That is the people who are vulnerable. And Dr. Wine was going to speak to this point a little bit about what are some of the disparate consequences of this pandemic for vulnerable populations.
Thank you, Rebecca. So I work in places and with colleagues where there aren't ventilators and there aren't ICUs and there isn't PPE, and you can't even practice social distancing. So you know that COVID is present in 188 countries around the world. It's present in 50 states in the United States. But you also know that there's widely varying manifestations of rates of infection, of deaths, of hospitalization. And it's clear that social disparities or social determinants and disparities are playing key roles here, but complex roles. Complex enough to merit 1,000 PhDs at the University of Chicago. Someone's going to have to unpack all this stuff and help us to understand it. But we can't wait for those PhDs because we know that we need to deal with this now. We need to understand social determinants and disparities, especially as many countries are now coming close to or entering into the period where they're going to be relaxing stringent social distancing. So just think about the US for a second. In the US, like in high income countries, there's a lot of variability within country, and it's clear that poverty and racial minorities are associated with increased COVID. For example, homeless in a Boston shelter have an infection rate of 36%. Which is extremely high. Chicago's Black population has 70% of the city's fatalities, despite the fact that it makes up only 30% of the population. So that's in a high income country where we have low resource settings that are rival what we see in low income countries. But now I'm going to talk about low and middle income countries as defined by the World Bank. Myself and a lot of others have expressed concern about the risks for COVID in low and middle income countries. Why? Because they lack high technology medical care, like we were just talking about a few minutes ago. They have weak public health systems. They have poverty, they have poor housing. If you look right now at the Johns Hopkins website on rates of infection, you'll see that amongst low and middle income countries, the most cases can be found in India, in Peru, Mexico, Pakistan, Ecuador, and Bangladesh. Well, why? I mean, in these countries, we find overcrowded slums, we find day laborers, we find refugee camps. These are places where physical distancing and even hand washing is often impossible. We at the UIC and our Center for Global Health are concerned about these issues. We work in 15 different countries around the world, 15 different low and middle income countries. And we did a survey recently, like the last week of April, of 40 different healthcare organizations in those 15 countries. And it was like a 30-item survey that was based on the WHO pandemic preparedness checklist. And we were trying to understand how ready were they to deal with this issue. And what we found out wasn't surprising, but it was an important reminder. First thing, they were very unprepared at the level of high-tech medical care. Only like 10 or 20% of them had capacity for ICUs and ventilators. We're talking about countries where they say they have 2 ventilators and they don't really know how to use them. But what we also found is that about, say, 65 to 70% of healthcare organizations were saying, yeah, we know how to do isolation, we have a strategic plan, we have PPE. That's important because like those capabilities don't necessarily depend on high technology, and yet 40% of them are still not doing it. So there's a room for growth there. What they also said was that only about 50% were confident that the patients and communities they work with could practice social distancing or hand washing at home. Why is that? Because they don't have running water, or because they live in a very overcrowded space. So these things are of concern. Now, interestingly, we can think about sub-Saharan African countries. Sub-Saharan African countries are not on the list of the highest countries that have been affected. And yet people are very worried about them for all the right reasons. I just heard today that there's an outbreak in a town in Nigeria, which is perhaps a bad omen. But one reason this has drawn attention is because these countries have actually strong public health response systems. I landed in Senegal in March and my temperature was checked in the airport. That would have never happened in the United States. So what's going on? These countries experienced Ebola, and these countries went through the drill, and they learned how to do surveillance and isolation and quarantine in a way that doesn't necessarily depend on high tech. So hopefully this will save some of those countries and their populations. Another concern, as you know, has been healthcare workers. We just did a survey of some 3,000 healthcare workers around the world in 60 different countries. And what it showed is that 51% of those healthcare workers were reporting burnout. What was burnout associated with? It was associated with the kinds of things you expected: high workload, job stress, time pressure, limited organizational support. Interestingly enough, the rate of burnout was significantly higher in high-income countries than low-income countries. We have a theory about that. We think that doctors and health, it's not only doctors, it's nurses also and others, I'd say are a little bit more privileged in high-income countries, don't face the kind of adversity that they do in low-income countries, and maybe had a bigger drop from the baseline that they thought they were operating at and what they had to operate under. I think healthcare workers in low-income countries didn't have that same privilege. You might also say they were more resilient in low-income countries. It also brings up the issue that we deal with in the class I teach at in the threat management course about how do you prepare first responders for dealing with the consequences of disasters. Well, I don't think that healthcare workers have gotten enough of that over the years, but now we're learning that in a disaster context, healthcare workers are like first responders, and so they need all the kinds of protections that first responders get. And so this is a big challenge for the future. So what can be done? Let me close on just a few points. So first thing, many have spoken out that there's a lot more that high-income countries need to do to better understand and support what's going on in low-resource settings or in low and middle-income countries or humanitarian emergencies. Furthermore, it's been said recently that the across-the-board lockdown approach, which we've applied in the state of Illinois and in high-income countries, is simply not feasible in low-income countries where you have large numbers of people who are dependent upon subsistence wages and who are now starving. And and you just don't have the possibility of physical distancing. So what can be done about these things? I think that the international community needs to do more to support low and middle income countries to cope with the pandemic preparedness, acquire PPE, acquire other medical supplies. I mean, they're never going to be equipped to the degree that high income countries are, but they can be better equipped now. And high income countries did a great job in helping with, say, the Ebola response. That needs to be doubled down now in the COVID response in low income countries. I think that also, despite the obvious resource limitations those countries face, there's a lot more that they could be doing by way of surveillance, training, contact tracing, isolation that isn't resource dependent, but is a challenge. How do you do that, say, in the largest refugee camp in the world with Rohingya in Bangladesh, where there's 1 million people? It's a big challenge for how to figure that out. It's going to call for innovation and resourcefulness and entrepreneurialism in low-income countries. And we look to those countries and their resilience to try to show what works. All the answers are not going to come from high-income countries. Around the issue of burnout, I think that a lot more has to be done by healthcare institutions and by government and non-governmental stakeholders aimed at potentially modifiable factors, providing additional training, organizational support, support for family, PPE, and mental health resources. Even such a thing like the state of Illinois or the city of Chicago has this great website on self-care for healthcare workers. That kind of thing is being employed in other countries in other languages and can be accessed over the web without cost. A lot of folks who are never going to seek traditional mental health services could benefit from those kinds of supportive resources. So last points, we know very well that virus is not going to respect borders and that it's going to persist in places where there are disparities and social determinants. So low resource settings in high income countries or in low income countries. So this has big implications for what we hope will be the coming vaccine and for access issues. We can't just give the vaccine to rich people or rich countries. We're going to have to find ways to get the vaccine into low-income countries as well. All countries need to do a lot better job in terms of following pandemic preparedness guidelines, including the US, which abandoned them, but also low-income countries, which in many respects have done a better job than high-income countries. And lastly, we need international cooperation. We need to rely upon the very organizations that are being dissed these days, such as the World Health Organization, because we don't have anything else, and they have, in many respects, done a good job. They're not perfect. There are a lot of problems, but we should be investing and supporting them for the future. Thank you.
Thank you, Stephen. You referred several times to resiliency and the fact that life has to go on. People need to be fed, housed, etc. And one of the things that has to happen in this country is the same thing. In spite of the Chicago River flooding or hurricanes bearing down, there's day-to-day infrastructure that needs to be maintained. And Mr. Bunge was going to talk a little bit about his role in literally keeping the lights on during this pandemic.
Thank you, Dr. Wirtz. So my name is David Bunge. I work for Commonwealth Edison. And as Dr. Wirtz mentioned, I was also a former student at the program at University of Chicago, graduated in 2016, and I'm currently also sponsoring one of the capstone groups there. So thank you for having me. So I'm going to talk a little bit about at the very local level at Chicago and Illinois level. Dr. Wine talked a little bit about the global level. I'm going to bring it down to the boots on the ground and talk literally in our own backyard here about what ComEd is doing to keep the lights on. So for folks who may not be familiar with Commonwealth Edison, we are the power company in Northern Illinois. So If you look at a map of Illinois, the top third of Illinois is our service territory, including the city of Chicago. So we span approximately 11,000 square miles. We take up about 25 counties, 400 municipalities, including the city of Chicago. And we're about 70% we serve about 70% of the state of Illinois, approximately 9 million residents in the state of Illinois. So when you think about a lot of the critical infrastructure in the city of Chicago, O'Hare Airport, the Sears Tower, Wrigley Field, or Comiskey Park, some of those pieces of critical infrastructure, we power all of those pieces. And it is critical that even during the pandemic that we're facing, that we keep the lights on. So normally, my team at ComEd is responsible for the day-to-day emergencies, if there is such a thing. So storms are the biggest thing that we face, and we respond to. We bring in first responders at the power company at ComEd, and we make sure that we restore power in a priority. We also face things like cyber attacks, workplace violence events, flooding, if we had a large regional blackout, or the Chicago Marathon, things like that. My team prepares for those more common events. And now we're really we're all in and completely responding to the COVID-19 pandemic. So regarding that, again, at the boots on the ground local level, I want to talk about three things. I want to talk about how we're protecting our employees and customers, how we're keeping a focus on critical infrastructure, and then in general, what we're doing to keep the lights on during this pandemic. And I could talk for hours on each one of these things, so I'll try to keep it very brief. So as far as protecting our employees at ComEd, like many businesses, our employees are the most important thing, and their safety is our number one priority, and the safety of our customers. And early on during this, one of the first briefings that I gave to our chief operating officer, the question was, how are we protecting our employees? And one of the things that we did is we went to the CDC website and took posters, and we just plastered posters of those messages that you've heard many times about covering your cough, washing your hands, not touching your face. We put those all over all of our buildings throughout ComEd service territory in Illinois. Also enables social distancing. When the disease came to the United States and we had the stay-at-home order, we told all employees to work remotely. So the employees that could work remotely, we told to work remotely. Unfortunately, what we do, the nature of our business, not everybody can work remotely. We need linemen out in the field, putting lines back up, fixing poles, and the nature of our business is dangerous. So we also needed to ensure that we could do our job and restore power while at the same time either maintaining social distancing or wearing the right PPE. So, and this was very, very challenging. So Dr. Wertz mentioned the Sears Tower. The Sears Tower recently flooded, and there is a large electrical vault that ComEd owns in one of the sub-basements of the Sears Tower. So imagine trying to do work in a basement or a vault or a manhole with a team of 4 or 5 people trying to maintain social distancing. Sometimes it just can't be done. And so in those cases, what we did is we outfitted all of our linemen, all of our operators with PPE. So in that case, N95 masks. Eventually, as the pandemic got worse, we outfitted all of our employees with face coverings and masks. So even the employees that still have to go into offices are wearing masks. So we also canceled things like meetings. We canceled conferences, which I know a lot of people were looking forward to throughout the years. I've gone to many conferences. A lot of people have had to cancel those trips because of being on planes. And our focus just continues to be on the safety of our employees and the safety of our customers. So if you saw a ComEd truck recently in your neighborhood, there may be a magnetic sign on the side of that truck saying, please keep your distance, stay 6 feet away for your safety and for our safety. Because there are many people that want to come up and find, when they see a ComEd employee, someone from the power company, they want to know what's going on. And that's their natural instinct. So we've told all of our employees, be polite about it and just ask people to maintain that social distancing of 6 feet. Even when there are jobs where we have to go into residences or commercial businesses, we try to call that business or call that residence ahead of time and remind them, when our employee shows up, please open the door and back away and give 6-foot distance as much as you can, so that we are maintaining that social distancing and protecting our customers and our employees as much as we can. And most importantly, we told employees that if you're sick, just stay home. Don't come in. Unfortunately, we have had many cases of COVID. Some of our employees test positive. And in those cases, what we would do is contact tracing. And so our occupational health services group would go back, and anyone that had close contact with those employees who tested positive would then be quarantined for 14 days and told to stay home until they no longer show symptoms. The next thing I want to talk about is helping critical infrastructure. So again, COVID, pandemic or not, these facilities, critical infrastructure has got to stay operational. In early March, we held a briefing with the Office of Emergency Management and Communications in Chicago, specifically to talk to them about what we were doing to prep for COVID-19. And we asked them, what are some things that we can do to help you? Even before that meeting, what we had already done is we had identified every hospital in our service area in the 11,000 square miles that we operate, and we double checked all of their critical operating systems, and we made sure that their feeders and maintenance was done, so that there was no surprises, that there wouldn't be a piece of equipment that failed and then all of a sudden we lost a hospital. So we double checked all of those, and we did extra inspections for all the hospitals in Northern Illinois in March, knowing that the healthcare system could potentially become overwhelmed or stressed because of this pandemic. The second thing we did to help out with the state of Illinois, when they began opening their COVID testing sites, a contact that I knew from the state of Illinois called me, and they knew that we had an asset that they needed, and we gave it to them. So what happened was, when they went to the Harwood Heights emissions testing site, which is a drive-through COVID testing site now, there was a gap in the road, and there was sort of a ditch there, and they needed sort of like a bridge to get over that so customers could go through and get their testing. Well, we just happen to have one of those bridges. It's a mobile bridge that we never thought we'd use for COVID during a pandemic, but we use it to reach broken poles. We use it to get over swampland and things like that. And so we deployed that. We got the call at 9 o'clock in the morning, and that day at 5 o'clock in the afternoon, we deployed our mobile bridge so that the Illinois National Guard could stand up that COVID testing site, the drive-through COVID testing site. So we're really happy to help out in that way. Once more and more COVID testing sites opened up, we took all those addresses, our external affairs group took all those addresses and sent all the addresses to our dispatching center. So we listed those testing sites up there with other critical facilities like hospitals and nursing homes, so that we knew if there was ever a power outage at one of those drive-through testing sites, that we would get someone out there immediately and prioritize that to ensure that that testing could continue and it didn't stop because of a power outage. Next is Mccormick Place. As most folks know, Mccormick Place was transformed into a 2,000-bed field hospital, and they were bringing in all kinds of additional medical equipment that, of course, needs power to operate. So we sent out our engineers to work with the building engineers at McCormick Place and worked with them 24/7 until that facility was stood up and operational, and we prioritized that. There were daily report outs to our chief executive officer about the status, and if there was anything else that the city of Chicago or state of Illinois needed from our end, we would provide that. And then lastly, ComEd owns a fleet of generators. These are backup generators that can be deployed to critical facilities. Knowing that the pandemic may stress the healthcare system, we went out and rented additional generators to add to our fleet that we could deploy to critical facilities. Luckily, we haven't had to deploy any of those so far, knock on wood, but we had those at the ready. Finally, just delivering reliable power to everyone, so keeping the lights on. For those of you who may not be familiar with how our system is designed, all dispatching in the ComEd service territory takes place in Joliet, Illinois. It is the nerve center of all operations in Northern Illinois for power. So one of our key assets there is that building and our dispatchers. And a big concern that we had is that if there was an outbreak of COVID-19 in our dispatch center and 40%, 50% of our dispatchers became sick, we would have a very hard time keeping the lights on a day-to-day basis. So we took a couple courses of action here to protect ourselves against that. So the first thing we did is we took a group of our dispatchers and just took them out of that operating center and moved them to a backup dispatch location. So at least if there was an outbreak in that critical facility, we would have a group of dispatchers that could do some minimum dispatching to keep the lights on. And so we split that up and they could maintain some minimum operations. The next thing we did, like I think Dr. Wine talked about, was health screening or temperature screening. So every single person that walks into either one of those dispatch centers gets their temperature taken by a healthcare professional. And if their temperature is above 100.4 degrees, they're sent home and they're told to monitor themselves to see if they have COVID and to get tested. If they have a temperature under 100.4, they're allowed to go indoors, and we test them twice daily just to make sure that their temperature hasn't changed throughout the course of their 12-hour shifts. And then the last thing, again, this kind of falls into the category of things I never thought I would do at a power company, is develop a sequestering plan for our dispatchers. So sequestering basically means that we're going to take a group of dispatchers, about 30 of them, and put them in a hotel and isolate them from everybody else. And the only things that they would do is they would go to the hotel, sleep, come to work, go to the hotel and sleep, and do that for about 30 days. So again, luckily we have not had to pull the trigger on that plan, but we have a hotel that is identified for our dispatchers. And in the event that our normal group, if our population of dispatchers dwindles to a point where we're worried about this, we would take that group of healthy dispatchers, we would test them first. Hopefully if there's enough testing capability, we would test all of them. But we would test those dispatchers and then sequester them to a hotel where we know that batch of healthy dispatchers is available. And then we would take the group that are at the dispatch center currently where there may be an outbreak, and we would tell them all to go home and quarantine them, and they would stay there until they don't show COVID symptoms anymore. So again, we've not had to implement, but we've developed a plan and we've benchmarked that across other utilities in the industry. And like I said, just because we have a pandemic going on, it doesn't mean there aren't storms or floods or other things like that. And when we activate our storm centers and bring in storm response, we mobilize about 184 people per team per 12-hour shift. And what that usually means is that everyone is coming together in an emergency operations center or coming together in other rooms to manage this emergency. So we've really had to change the way that we operate our storm response. And we've been able to identify about 2/3 of those people that can work remotely now. You lose a little bit of productivity, but at least you're not exposing folks to other people who could have COVID. We've also identified ways to socially distance the people that have to come in. We've enhanced the cleaning schedule so that there's a cleaning before a shift, between shifts, and then after the last shift goes home. And then we finally identified a way to do a remote turnover so that when Team Alpha leaves the Emergency Operations Center and Team Bravo comes in, instead of a face-to-face turnover, they're doing a virtual turnover over phone or over a webinar like we're talking about now. And then we've also, in cases where we have large storms, we sometimes bring in mutual assistance. So we bring in crews from across the nation, including as far as Florida at times, to come in and assist ComEd in storm response during a large enough storm. So we really had to modify our process to, instead of those morning huddles where we bring all of our crews in at one location to talk about the jobs they're going to get, to do that virtually, to do our safety briefings virtually, to when we hand off material like poles and conductor and things like that. How do we do that in a socially distant way? And how do we test people and monitor them to make sure we're not bringing someone with COVID from a different state across the nation to the Chicago area and now spreading it? So we really had to modify a lot of our processes to make sure that we're doing that safely and not exposing, again, our employees or our customers. So where are we at now? Obviously, COVID is still going on. and we're still facing some challenges with COVID. And our next steps now are really, we're hoping that we see the light at the end of the tunnel. And, there's a lot of conversation about return to work and what that looks like. We're really in the infant stages of that and identifying, what groups we would bring in first, and what does our office look like now? How do we have office buildings with cubicles and meeting rooms, but that are also able to maintain socially distancing? So those are the things that ComEd have been working on during this pandemic.
And that actually makes a great segue. Thank you, Mr. Bungie. I think most organizations had a continuity of operations plan or an emergency response plan, but I very much doubt that any of those plans planned for episodic waves that might last for a year or more. Mr. Russell is going to talk to us a little bit about how to keep an organization operating, and how to keep it operating even as we evolve into the next phase of this pandemic. And Mr. Russell, I think you're on mute. I'm going to unmute you. There you go.
Am I unmuted now?
Yes.
So yes, thank you. In addition to being an alumni of the program in 2012, I also work at Gallagher, which is one of the largest insurance brokerage and risk management firms in the world. We have more than 35,000 employees across 700 plus locations. So our considerations are a little bit different. We have to think about cultures, regulations, government requirements as we kind of go forward with this COVID-19 response. So for my topic, I'll plan to cover some general considerations, and hopefully attendees may find some of these helpful with their planning. So whether you're leading a crisis for a global operation such as Gallagher or more local, organizations will ultimately benefit from having a cross-functional team. This might be called an emergency management team or a crisis management team, but essentially it's members from key departments that meet frequently to allow information and decisions to flow into and from this team, so that they're speaking with one voice as an organization, internally and externally. A structured and a phased approach, dividing your response into manageable phases, and even developing a matrix that identifies key actions per phase and who is responsible for it. Have accountability, and being able to hold people to deadlines is really important when you're really kind of crunched for time, especially at the beginning of this response where government organizations were locking down or having to stay in places. And for Gallagher, it was happening all over the world at different time zones. So it was coming in at night, in the morning. So you have to have a team, and then you have to have a structured approach, and people have to have ownership in some of those actions. Another important item is relevant intelligence. Have each business unit provide a briefing on how they're handling each of those actions. Know what is working and what is not. Getting credible data that relates to your organization, so decisions are based on data, internal and external. So you can get that from the team, but was also mentioned today, there's a lot of sources out there, and making sure that they're credible and also that they make sense for what you're trying to accomplish as an organization, because it can get overwhelming. Those three bullets alone will allow you to have greater strategic alignment across the business while considering the nuances and decisions that may vary based on geographies. Also, greater awareness on the current environment, whether that be operations or employee well-being, and ultimately accelerated change across the organization. So with the team and approach and frequent briefing taking place, most organizations, like Dave has mentioned, is now in the stabilizing operations. So they've moved from the initial safety, whether it be travel or just the health and safety piece. They've kind of moved through business continuity, and now it's how do we stabilize operations for an extended period of time. This isn't just 2 weeks working from home. This could now be months, potentially. So I'll provide some actions that all organizations may consider in this phase. With some organizations now managing a remote workforce, where you have to communicate frequently with employees. So most employees are not used to being away from their coworkers, their manager, partners for an extended period of time. They may have fears about job stability, obviously the health concerns that they might have for them and their families. So they need to feel like they aren't on an island. And the messaging and tone is also really important here. So you can emphasize the importance of physical and mental well-being. You can get creative. We've created running groups that compete against other locations, webinar check-ins or internal trivia where employees can win prizes. It's about engaging employees outside the normal conference calls. And be honest about the steps the company is trying to take, even if they're unpleasant or you don't know exactly where you're at today. And then also educating employees and managers. Employees might not know how to get into a routine now that they're at home, or managers might not know how to manage a remote workforce if they're used to those people being in an office. So this is the time for organizations to really educate and bring best practices to help guide them through this transition. Another consideration is about how we handle suppliers and customers, because that is obviously changing. So one thing to suggest is constantly learn and adapt. What might work one day may not work the next day. So having a constant pulse on IT and operational issues so that they get resolved before they grow too big. The other thing is you can apply that same concept to, I like to see, kind of keeping the pulse on what's going around. And that can be done as monitoring supply chains or inventory as well, especially given the different disruptions or shortages or at least flux in demand that we've seen so far. And then communicate what the company is doing. Stay in touch, and most importantly, we have to focus on how we're going to deliver during this time. And the final consideration in this area would be around financial and employment decisions. Being able to forecast the demand or cash flow, not just for this quarter, but further out to help make those decisions, those tough decisions. Unemployment is at record highs, and there's still many uncertainties still ahead. Organizations need to think through those tough decisions and whether they'll be doing reduction in force, pay cuts, while still maintaining and attracting top talent. So communication and tone, as mentioned earlier, is also really important here. Keeping spirits up in the teams will become more difficult, but all eyes will be on the leadership at these companies and organizations as employees are really kind of focused in on what those decisions are, whether they agree with it and want to stay on board with the company as well. I think it's important to note that while organizations may be stabilizing operations, they have to plan ahead as well. And part of that in the crisis or emergency field is scanning for other threats and challenges. So if you look at cyber exposure, in just 1 week, it was reported that more than 18 million COVID-related malware and phishing emails occurred per day. With a large majority now of organizations working remotely, this opens up risk to cyber incidents and the damage it could really have on organizations than it did maybe before. So understanding what new gaps this new normal creates allows organizations to proactively adapt their cyber strategy. And natural disasters, as Dave mentioned, right now, at least in the US, floods, tornadoes, wildfire, hurricane season, these do not stop for a pandemic. So organizations really need to be thinking about how they're going to handle other threats as they present themselves. What business continuity strategies are in place for a remote workforce? Many organizations use their backup plan or business continuity plans for the pandemic. So what's the backup plan for the backup plan? And just think about this, and Dave mentioned it a little bit, evacuating, to a shelter, an out-of-town hotel, or staying with family or friends may not be a viable option for areas with high COVID risk. And organizations will need to start thinking about those scenarios now so they aren't caught off guard or too focused on what's going on with COVID. And a topic that really needs about 8 hours to discuss, but I'll try to do it in a couple bullets, is reopening. And some organizations may have never closed. You look at retail, portions of businesses such as, utilities, and they've had to really deal and adapt and align to government restrictions and customer demands on the fly. But whether your organization never fully closed or you sent employees home, all organizations are trying to determine that right balance between reopening or staying open and the health and safety of employees and customers. So just some considerations is, organizations, the ones that I talk to, are really trying to figure out a risk-based decision process to navigate government directives, health data, office and store risk, economic impacts, and then employee concerns, whether they want to come back or not. You may also need to reconfigure workspaces or stagger teams and shifts to meet the physical distancing standards, as Dave mentioned. And also being able to just secure PP masks. It's one thing to say that we need it. It's another to actually be able to secure those now, source them, and get them to our operations. And being able to think through and prepare for a potential second wave, or if you have some type of infection in the workplace, what are those protocols? What does that look like? Can employees adapt quickly to that change? And then just overall educating our employees on this complete change of what this office or workplace looks like, whether they're at home or whether they're coming in the office. And I'll kind of just leave, with this. I think the goal of any crisis is to become more resilient and stronger than before. For those of you that are responsible for crisis events, now is the time to look at lessons learned or areas that worked well so that they're not forgotten. If your organization isn't coming out stronger or more prepared to handle a crisis, then I think you're missing a big opportunity with this one. The two areas I'm sure that we've all seen on the news, organizations that are considering new technologies, limiting their real estate footprint as they move more to a remote workforce, but don't also lose sight on some of the less obvious ones, such as a change in organizational strategy or new ways to service customers. This can be seen with the retail and restaurant organizations. I think they've shown great resilience in some of these areas. They've adapted to how they package foods or how they have different deals to entice people, contactless pickups and deliveries. All those things, as you start to go back to the new normal, you should be considering kind of how you can adapt those as you adapt your organizational strategy in the future.
Thank you, Mr. Russell, and thank you so much to all of the panel members. Now we have time for questions, and there have been several questions submitted, and please feel free to go ahead and submit questions via the chat box. The first question actually relates to children, which I think is a fascinating and pressing problem. I think there's going to be a whole cohort of children for whom this pandemic is serving as an adverse childhood event and what impact that will have on them for the rest of their lives. Maybe we could get Dr. Kim and then Dr. Wine to speak to the specific question, which is what effect does the physical distancing potentially planned for schools have on school-age children, both academically, mental health-wise, socially, and does that, how does that help us weigh continuing to do remote learning versus returning them to school? Dr. Kim, any thoughts about that?
Yeah, in fact, my research currently on the school side is on social emotional learning, and this COVID-19 really changes the way we ought to practice, which is something that we've been talking about it, but it really pushes the conversation to change in a real way. And what I mean by that is, in particularly those institutions that deal with education has always put academics in front. And when it comes to issues like social emotional learning or well-being of children in general, we always sort of thought of as a secondary. I mean, social emotional learning has always been like after school program or once a week. It was not part of a school process. Now, I think we need to put that in front rather than in the back of our curriculum. And to do so, we really have to change the mentality of how we identify what you just mentioned, the adverse childhood experiences. I think the way kids perceive routine really has to change in a big way. The way they interact. I mean, Tom has mentioned, creating routines. For kids, they crave routine, but what they have gotten used to so far somehow has to change a little bit. And to ask our children to change that is much more challenging than it is for adults. So, creating this structure, whether it be physical or emotional, I think they all have to change. And educators really have big challenge here, because we've been doing very traditional same way for a very long time, and for us to rethink this within next several months is incredibly challenging. And to add to that, with changing demographics, and I think Stephen had mentioned this before, one of the most uncomfortable conversations that we adults do not like to have is this concept of race in this country. And we have, you know, much larger proportion of children that are Black and brown kids. And clearly there's a gap there, there's a disparity there. It's something that we really need to address head on, not just see it as issues to address down the road. I think it's much more pressing given the demographic shift. I think we really need to have that honest conversation.
Dr. Wine, what are your thoughts about mental health of kids in this situation and the role that school plays in trying to help address those issues?
Mm-hmm. Well, things have changed for kids, for sure. And we don't really know what the impact or outcomes are going to be. I think we should be monitoring that and letting that inform our policies and our practices. I think that the kids' immediate experience is shaped most by families. And so I think that, I mean, schools are very important, but so are families. And so I think this is an incredibly stressful experience for families and difficult time for parenting. Not equally different for all families. I think the family has resources and supports, then they may be better off, you know, and the kids may fare better. So I'm concerned about, again, about disparities there. But I think about the principle of family resilience. We've studied a lot about family resilience, for example, families of refugees. And we've learned a lot about what are the aspects of family resilience that make a difference. Flexible and reciprocal family organization, hopeful family beliefs and communication, that no matter what's going on, it's going to be okay. It's important for parents to communicate that. Staying connected with family, of course, through things like Zoom, but also maintaining family rituals, meals together, bedtime reading, and making the best of living in a new context. So there are kinds of resilience strategies that have been seen in families across many different types of adversity, which predict child outcomes. So I think that what schools and communities could be doing, or faith organizations or healthcare organizations, is helping to support and encourage this kind of family resilience.
Great, thank you. And I like the idea of supporting family resilience. So here's a second question from the listeners, and I'm going to pitch it to Dr. Foster. A few states have recently been accused of manipulating or misrepresenting data to support their agendas. I'm going to broaden that statement and say that throughout this, there have been people manipulating data to support their agendas. Dr. Foster, what are your thoughts about the consequences of that in terms of, you talked about trust and believing in the communicator. What are your thoughts about these recent accusations of states manipulating data in order to support a reopening agenda? And I think you're on mute. There you go.
It's a bad thing. If we can't trust the people who are providing us the information, then we can't trust them. And that's a blanket thing. If you're lacking in little, you will be perceived as lacking in much. And I happen to live in one of those states you are referencing, and it's been an enormous controversy here. I live in Florida. Been an enormous controversy here that the state medical examiner's office is withholding information, not answering questions. And it's causing people to doubt the numbers that are reported here on a daily basis, county by county, as far as new outbreaks and numbers of deaths. We can't trust those numbers anymore. It's a very unsettling thing.
Very destabilizing. Yeah.
Yes.
Another question here, and I'll pitch this one to Mr. Bungie and Mr. Russell. How should companies go about enforcing social distancing when people return to work? I've seen, on Facebook, the pool noodle idea that a bar in Germany is using, and the inflatable inner tubes that a restaurant is using that patrons wear around their waists. What can a company do to try and enforce, especially in open office settings, enforce that kind of social distancing?
So I'll take a crack at this first, Tom. So, I mean, the best thing that I think we did at ComEd was just tell people to work from home and not allow folks to come into the office. I think that's the best possible thing. But as I mentioned, there are some essential employees that must come into the office. So what we've done in those cases is we've removed chairs in conference rooms so that folks couldn't, a conference room that previously fit 30 people only fits maybe 10 people now. And we've actually redesigned some of the dispatching stations so that folks that their workstations are physically 6 feet apart. And one other item that we're researching now is we're looking into proximity devices. So having people actually wear a proximity device that will buzz or alarm people when they get in too close to someone else with a proximity device, so to indicate to them that they are within that 6 feet distance. Other than that, when we do our safety briefings before any job out in the field, one of the first things we talk about is the required PPE and social distancing.
Mm-hmm. Okay, and so implementing what I would call engineering controls, redesigning the workplace on the fly to make it more amenable to that kind of social distancing. Mr. Russell, did you have anything you wanted to say?
Yeah, I think, one consideration is before we get into the workplace, there should be a pretty good risk analysis going on. So, just because a state opens, for example, doesn't mean we're all going to rush back if we're able to maintain operations from home. So maybe it's looking at localized county data to see if there's certain hotspots or trends to determine what offices might fall in an area that is less risky, even in a general state or a general country, especially smaller countries for us. We have New Zealand, who has really kind of seen drop in numbers the past few weeks. And then the other thing is kind of looking at each office. Not every office is the same. So offices that you have to take an elevator up 15 stories and it's shared with 100 other tenants, that risk goes way up to us. So we look at where can we just walk in? We're maybe on the first or second floor. Maybe we're the only tenant or just one of few and have our own door that we can use. So understanding those, and then to Dave's point, kind of then looking at the physical workspace. So do you take temperatures? What are concerns? Is that collecting employees' information? Does that go against regulations? How do you get around that, or can you not do it at all? Getting PPE, looking at the floor plan and maybe having social distancing markers and the flow of the office and where people can stand. You see this in retail probably if you're out at stores. So I think before you get in, you have to analyze the geography and the data and the office. And then to Dave's point, I think then you can really look at then how do we change that workspace to make it sure that it's safe for our employees. And you can damp that over a phased approach. So you start small and you kind of raise it up over time, get people used to the idea. No one's used to wearing masks and waiting for someone to come out of the bathroom before they can come in. So we just have to really kind of put put perspective on the employees in that office and kind of adapt accordingly. Great,
thank you. So there's one last question here, and I'm going to give each of the panelists a minute to respond to it. Mr. Russell actually called this an opportunity. And I think a lot of us have thought about how we will want things to be better, how we'll bring back better, right? What are we hoping will come out of this that will address some of the problems we've seen in our professional lives or in the systems that we work in? what is it that we could hope or expect and build toward as we try and build things back? And I'll ask people to go in the order that they spoke initially. So Dr. Foster, what would you like to see that would be different as we come out of this? And I'm going to hold everybody to just a minute. So,
well, from a personal point of view, I certainly hope we come up with a revised set of priorities for ourselves and for our various professions. But also speaking as an educator, I think we've started to learn that there are a lot of different ways to teach and a lot of different ways to learn. And the fact that those doors have been opened for us, not willingly on our part, but we've sort of been forced on us. And some of us are, I think, finding that we like them and that we can do more with them than we thought we could. I hope that transcends to a lot of other professions as well.
terrific. Dr. Vogenboom, what would you like to see differently? What happened different?
Well, I've been amazed at how the research, the world of research has adapted quickly to the needs to get data out quickly. My main research interest is in assembling and sharing research data, and to see the community come together and quickly put data sharing agreements in place, to see IRBs adapt on the fly, to see data requests and research requests go through quickly has been just amazing to see how they could rise up. And what I really hope is that once things slow down, that we don't go back to our old ways of siloing data and not sharing it. I really hope that this new spirit of collaboration keeps moving forward, because it's been great to see.
That has been fascinating, yeah. Dr. Kim, what would you like to see different going
Yeah,
forward?
I'd like to expand that, extend the sentiment to policy as well. I think that connection between research and policy has been somewhat loose. I mean, the way we think about institutionalizing what ought to be, I think can only be accomplished when you have rules and regulations that that guide behaviors. And I hope that what we learn out of this experience is that research really has contribution to human behavior through institutional mechanisms. I really hope that that connection becomes more firm and rapidly implemented. Otherwise, we just have this academic conversation and then that's the end of the road. I hope we don't go back to that.
So to translate research into policy and policy into action much more quickly than we've done in the past. Yeah.
Absolutely.
Interesting. Dr. Wine, what would you like to see come out of this?
Three things, of course. The first is preparedness and prevention, a commitment to preparedness and prevention. There's going to come a time soon when people are going to say, oh, the crisis is over. We're out of it. We can forget about it. We don't need to prepare for the next wave or the next flu or the next scary disease. Let's make a commitment to preparedness and prevention. Two, a strengthened global architecture for really delivering preparedness and prevention. It has to be strong enough to stand up to the likes of our president and others who not only, who don't follow accepted science and spew misinformation. It has to stand up to conflict, interstate conflict. So this is a big thing. And then the third is greater appreciation and greater access to psychosocial and mental health resources. So many people now know what it is to worry, to fear, to be isolated, to be depressed, and they're looking for help. Can we find other ways to get them help other than traditional services, and perhaps especially through digital means?
Thank you. Mr. Bungie, what are your thoughts?
Yeah, I think what we can get out of this, and Tom Russell is completely right, this is an opportunity for everyone and our field of emergency management. And I feel that what we could get out of this is building a bigger culture of preparedness at the national level, at the personal level, everyone to be prepared, and then at the government and business level. And I really think that this pandemic has shown a spotlight on whether or not that business or that government has had an emergency management group or an emergency preparedness group, and whether or not that group is robust enough. And I think that you'll see in the future a larger demand in the workforce for people in the emergency management field and the business continuity field. And I think some of the students from this program are the perfect candidates going forward.
Terrific. And Mr. Russell with the last word.
I wrote down a list, and everyone covered all of mine. So I couldn't have said it better than they did. But I guess, one thing being from a resilience background is I'd really like to see organizations understand that, a number of people can actually do work remote and less focus on the office space and more about building connections with, whether it be our customers or our colleagues. And would love to kind of see it open up doors to people that are all over the country that can kind of work for these companies that are global and don't have to be physically in the office, and I hope that opens up some of those opportunities for people.
Terrific, thank you. And I think Mr. Bunge's call to the students in this program and the young alumni, it's your world, it's your chance to make things different based on going forward and building back better. And those of us on the panel are counting on you to make that happen. So thank you all very much for participating. Thank you to the panel members for your insights and your thoughtfulness and all the work that you're doing to try and help us get through this.
And thank you, Rebecca, for being a great moderator, and panelists for having a really good discussion. We hope everyone has a good rest of their evening.